Hi everyone, we're gonna go ahead and get started. If you haven't already, before you leave, there are a couple of sign-in sheets outside on the counter there, so just make sure you sign in so you get credit for the CEs.
Well, good morning, everybody. I'm Doug Russell, and on behalf of myself and Michelle and Jolie and Channing and Dell and the rest of the Grand Rounds planning team, welcome to a new season of Grand Rounds. We're really excited about today's talk and today's speaker. And we're also really excited to have this be in person today. It was really wonderful to hear all the buzz and the conversations happening prior to start today. I think in this day and age, we need to lean on community, right? And find opportunities to get together and share ideas. So that was why we made this first Grand Rounds an in-person experience. So thank you all for being here. We'll start with a land acknowledgement. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people past and present, and honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with indigenous communities, but serves as one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of the free and slave labor of Black people. We honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of privilege and oppression and how they play a role in the lives of patients, families, and employees as we strive to be anti-racist and improve care for those with less privilege. We like to highlight cultural happenings every month, and so we wanted to highlight this month that we're in the middle of National Hispanic Heritage Month. And I just love these colors. All right, well, I am really excited to welcome Nathan Sackett to the Grand Rounds stage today. He's going to be giving us a talk called Psychedelics for Addiction, a primer for providers. This is obviously cutting edge stuff, and we're really happy to have him here. Dr. Sackett is an assistant professor at our division, just across the way. And he serves as the director of the Center for Novel Therapeutics in Addiction Psychiatry, or NTAP, where he manages multiple $1 million, actually, of state funding for cutting-edge research and a team of 12 psychologists and psychiatrists in addition to staff. He's also served on the Washington State Healthcare Authority work group for psilocybin and is a highly sought-after educator and mentor in our division with a really interesting path to psychiatry. He started his journey in healthcare in 2004 when he got his Bachelor of Nursing and worked in palliative care for almost a decade before deciding to go into medicine. He got a master's, an MS at Berkeley in 2014, then his MD at UC San Francisco in 2016, and then somehow UW was able to lure him up to the snowy peaks and soggy seasons of the Pacific Northwest, where he did his residency and addiction fellowship. This is sort of the cutting edge of our field. So really excited to learn more about it. There will be an opportunity for questions at the end of the talk. So take some notes while you're listening, and please join me in welcoming Dr. Sackett.
All righty, hello, good morning. How you all doing today on this bright and early Friday morning? We are Well, before I get started, some disclosures. I am a scientific advisor for a couple of companies, one called Camtech, one called IRA Retreats. Most of our funding does come from state funding, as well as philanthropy. And then, of course, just as a legal liability, I am talking about investigative agents and scheduled compounds. I'm not endorsing them, but we will be talking about them. Okay, today, there's really three primary goals of this talk. I'd really like you to leave here having some general understanding of how this research fits into the medical research around psychedelics over the last 100 years or so. I'd like to review a little bit of basic pharmacology on a couple of different compounds and some of their application for addictions. And finally, I'd like to review a little bit about how we conceptualize issues around safety and discussing with patients and families, what's going on in this field. I'm sure all of you are receiving questions in some way from family or friends, and I'd like to give you some language that might be helpful for that. Okay, so to that end, to reach those goals, we'll be talking a little bit about definitions, some history, and the overlap between addiction treatment and psychedelics. We'll be reviewing some basic psychedelics, including LSD, psilocybin, and ketamine, if we have time. And then talk a little bit about mechanism of action, some of the safety concerns, and sort of some of the language we use in talking to patients. Okay, so, we're at this really interesting time in history right now where there seems to be growing appreciation that addiction and substance use is causing increasing problems. And I think there is a growing need and interest in trying to find more treatments. As we all know, the treatments leave something to be desired for many folks. And so there's a lot of excitement. That said, it does seem as though the excitement and sort of the hope of finding novel treatments right now, the language being used in the media sort of exceeds the place of the scientific data at this point. So there's this discrepancy. And I spend a lot of my time living in that discrepancy, trying to explain to people, yes, we should study this, and no, please don't go out and take ibogaine in an unregulated environment. So it's this interesting position that I find myself in. Part of the challenge in these conversations, I think, is a semantic one, or the way in which we define psychedelics. And so I think it's helpful that we increase some specificity when we talk about these compounds. And to that end, there are sort of three different taxonomies that one can look at when thinking about psychedelics. We can talk about psychedelics as they relate to their receptor affinity. So we can look at things like drugs that interact with 5-HT2A, like LSD, psilocybin, and DMT. We can look at receptor affinities that are mixed, like MDMA, MDA, and iboga. And we can look at things like NMDA antagonists like ketamine, dextromethorphan, and nitric oxide. The second taxonomy relates to the chemical structure. And so when we're talking about the chemical structure, we can generally divide them into two broad categories. We can talk about tryptamines, which include things like psilocybin and DMT. We can talk about ergolines, which are LSD and LSA. Both of those are indolamines. And then the second main category is phenylethylamines, which include mescaline and MDMA. And then the third taxonomy is more descriptive in nature. So you've probably heard classic psychedelics as sort of a terminology. That generally refers to serotonergic agents like psilocybin and LSD. You may have heard the term empathogens, which refers to MDMA. And you may have heard the term a dissociative psychedelic, which generally refers to ketamine. So I think it's important to really hone in on what it is that we're talking about, especially in a time where media, there's a lot of hype right now. And so you might see a headline, psychedelics do X, and then you dig in a little deeper and they're talking about ketamine or they're talking about MDMA, which generally can't be, one cannot really generalize from those compounds to all of the other compounds that we're talking about. So from a history perspective, I think it's important to denote there is a lot of indigenous cultures that have used various psychedelic compounds for sort of psychospiritual, religious, traditional purposes for millennia. I'm not talking about that specifically. I'm interested in the medicalization of these compounds. So when I talk about its history, I'm really looking at, say, the last 100, 125 years. With that lens, I really think about the history of the way we study psychedelics as occurring in sort of 3 different stages. So the first stage, or the first wave, is what I call the discovery wave, and that's largely defined by mescaline. Mescaline was first synthesized in 1897. In 1913, the first healthy volunteer study was published with the administration of mescaline. And then in 1936, the first published study of psychedelic-assisted psychotherapy using mescaline was published. And then, of course, things pretty much stopped during the war, and then we sort of move into the second wave, or the experimentation wave. This wave was really defined by a couple of big events, mainly in the 1940s. Albert Hofmann synthesized LSD. He was a chemist in Switzerland and was working on a number of different compounds, one of them being LSD. He accidentally took some and biked home, which infamously became known as Bike Day in 1943. In 1947, after Hoffman's accidental ingestion, he strangely or surprisingly convinced colleagues of his and board members of the pharmaceutical company to try LSD, which they did, which is somewhat amazing. It shows the difference of time that we're in today. And ultimately, what he said is that by taking Dalicid, which was the branded name at the time, the psychiatrist is able to gain an insight into the world of ideas and sensation of mental patients. Dalicid can also be used to induce model psychosis of short duration in normal subjects, thus facilitating studies on the pathogenesis of mental disease. And this needs to be put into the context that, prior to the 1940s, schizophrenia, one of the first-line treatments was ECT without anesthesia. So there was very little incentive for patients to express their symptoms. I mean, I certainly wouldn't tell you my symptoms if I knew I was going to be institutionalized and have ECT and break my teeth and bones in the process. And so there was actually a push to administer LSD to trainees in psychiatry and psychology programs so they could better empathize with their patients. And it's estimated about 40,000 trainees in the 1940s received LSD for this specific purpose, which is interesting. In this second wave of experimentation, this was also a dramatic change in the way in which we conceptualize mental disorders, more wholly. In 1954, Woolley and Shaw proposed that serotonin mediates mental processes. And then, of course, we move into the 1960s with the Good Friday experiments done at Harvard by Timothy Leary. And then this is sort of the time period where it seems to have escaped the confines of the research domain and started to enter into the counterculture movement, which of course agitated quite a few people, and ultimately led to its association with protest and sort of anti-establishment, and led to the passing of the Controlled Substance Act in 1970, which sort of ended this experimental phase. It's worth noting, too, that in the 1950s and 60s, there was a big push in using psychedelics to treat substance use disorders, which we'll talk about. But that work all stopped after the passing of the Controlled Substance Act. When we move into the third wave, I call this the neuroscience wave. This was really started in 1985 with the first investigative new drug application that was filed by MAPS for DMT. And it took 9 years, but in 1994, Rick Strassman was the first to do a healthy volunteer study of DMT. And that really started to catalyze the scientific interest in the use of these compounds, and ultimately led to the first phase 1 psilocybin study for end of life that was published in 2006. And really, after that, you start to see a rapid growth in studies. And then you see How to Change Your Mind by Michael Pollan, which really sort of popularized this work and still seems to capture the imagination of many, many folks. Okay, moving on to addiction. So the most famous story that I'm sure many of you are aware of is that Bill Wilson, one of the founders of AA, had a personal experience in 1934 where he had struggled with alcohol use, had been in and out of treatment, and was admitted to a hospital in New York where they administered a mixture of different tropane alkaloids, of henbane and belladonna. And he was said to have had this experience where he saw this white light and it was transformative, and ultimately he attributes much of his success around alcohol use and remaining abstinent to this experience. And ultimately, Bill Wilson went on to take LSD a number of times, and he believed it was an incredibly useful tool in terms of increasing folks' motivation to engage in some sort of program. And ultimately, it was the belief of many researchers at the time, and Bill Wilson, that perhaps if you look at, say, 12-step programs, that psychedelics could play an important role in some of the pivotal steps in people's recovery, particularly around the second step of sort of accepting and surrendering to something, some sort of higher power, if you will. Then, if we move a little bit forward in the 1950s, Humphrey Osmond, who was a Canadian psychiatrist, began to notice in a hospital that folks who underwent delirium tremens seemed to have pretty disproportionate rates of abstinence. And so Humphrey Osmond basically wondered whether LSD induced delirium tremens. And so he developed the sort of format that is used today, the preparatory format, whereas you have preparatory sessions, you then administer the psychedelic with the therapist in the room, and then you have what are called integration sessions afterwards to try to make meaning for that whole experience. And it was really Osmond who developed this model, again, thinking that LSD induced delirium tremens. And so they started a number of studies that explored this, it was these studies in the 50s and 60s that sort of laid the foundation for the work that we're doing today. Okay, so now I'd like to move into some of the psychedelics themselves. I think, so LSD is an interesting compound. It sort of has historical significance in this work, although it is, I would say, today less of a compound of interest given the long duration. But I think it's interesting nonetheless. So what is LSD? It's a semi-synthetic derivative of lysergic acid, which is found on the parasitic rye fungus, C. purpurea. And LSD-25 is the formal name because it's the 25th compound that was developed in a systematic study of amides related to lysergic acid. In terms of its brand and class, so like I said earlier, LSD was branded by Sandoz Pharmaceuticals in 1947 to 1963 as Delicid, seen here. And I think what's interesting about Delicid is that as I said earlier, between 1947 and 1963, there was this push, whereas folks could receive Delicid as a research chemical, but you had to publish the data that you had. And so that led to a large number of papers and case series that were, arguably not well designed, but part of that is a function of the incentive structure at the time. If you as a psychiatrist wanted to administer this, you had to publish some sort of findings. And so that led to a large number of studies, many of which would not be considered high quality at this point. But there are some interesting studies that we'll talk about in a little bit. When we think about LSD, and I'm sure if you guys encounter patients with questions, dosing ranges generally are around, this kind of standard dose today is about 150 micrograms. The studies that have been done on LSD for healthy volunteer studies are anywhere from 50 micrograms to 200 micrograms, but studies have been done that range from about 200 to 800 micrograms. It is administered orally and absorbed orally, and when it's used illicitly, it's often applied to a piece of paper like this, known as blotter, and people put it on their tongue where it's absorbed and does its work. In terms of safety, there's a lot of, I would say, cultural residue from the war on drugs and the sort of, anti-drug culture of the 80s and 90s. But what's interesting about LSD is if you actually look at the literature, there's really not much attributable harm from LSD specifically. Now, there is obviously harm that can be done with any psychedelic based on situation, people making bad decisions, people like trying to fly and jumping off things. And so I don't want to tell, I don't mean to imply they're entirely safe, but from a pharmacology perspective, they're actually quite safe. And in 1974, this was illustrated in a case series of 8 adults who they inhaled what they thought was powdered cocaine, and it was actually crystallized LSD. And this was in San Francisco, and it's estimated they each took about 1,000 doses. They presented hyperthermic and agitated, understandably. And they all, 3 of the 8 went into respiratory failure, but they all recovered within 48 hours and were discharged within 48 hours. So that, I think, just goes to say that, even at high doses, the relative toxicity is quite low. And that's something to consider. So in terms of the relevant pharmacokinetics and how that plays out clinically, it's rapidly absorbed in the GI tract and orally, and that results in a pretty rapid onset of anywhere from 30 to 45 minutes. It generally peaks in the intensity anywhere from 1 to 2.5 hours and lasts from 9 to 12 hours. And then it has a half-life of about 2.5 hours or so. Now, I think, so this is an interesting plot. It's called a radar plot. And I want to take I want to go down a little bit of a rabbit hole for a second. When we research psychedelics and their subjective effects, there are sort of 3 primary outcomes that we use. We use what's called the Altered State of Consciousness scale. The second one is called the Hallucinogenic Rating Scale, and the third one is called the Mystical Experience Questionnaire. So all of these are self-reported Likert scales that sort of try to quantify different subjective effects of these compounds. Now you can probably appreciate that's a hard thing to do. By definition, the subjective experience of these compounds is such that it's very challenging. But probably one of the better tools used is the 5-dimensional scale of the Altered Consciousness scale. And here you see a plot of some of the domains that are on that scale. And in the blue line, you see 200 micrograms, and in the checkered line, you see 175 micrograms. And what's notable here is among the different subjective effects for LSD, you see a lot of audiovisual synesthesia, you see a lot of imagery, and there's, in terms of, if you look over at the oceanic boundlessness domain, which looking at things like blissful state, you see some effect. So keep that in mind as we move forward in some of these other compounds, because it gives you a sense of some of the different pharmacology and the different subjective effects. In terms of its mechanism, the primary mechanism in LSD is its association with 5-HT2A, which is demonstrated by studies where cantanserin, which is a 5-HT2A antagonist, is administered, which blocks the effect. There is some dopaminergic activity with LSD, primarily with D1 and D2, which is why it's thought to potentially, or it was thought in the 40s and 50s to be a good psychotomimetic. In terms of its evidence base for alcohol use disorder, so as I said, there's a very large amount of literature. Many of it is quite poor quality. But in 2013, Krebs and colleagues did a really great systematic review and meta-analyses of the studies that actually showed comparators and clear outcomes. And in that analysis, they compiled 6 studies of adults who had a single dose of LSD, and the sample sizes among the studies were variable, anywhere from 20 to 176. But in their pooled analysis, they looked at 325 adults who received LSD, and they compared that to generally like treatment as usual conditions of about 211. And the primary outcome was abstinence at 1 month. And here you can see in the red box that when they pooled this, the odds ratio of folks who remained abstinent at 30 days was approaching 2. So putting this in simple terms for me as a simple clinician, what's that mean? It means that for folks who received LSD who wanted to remain abstinent in 30 days, there was about double the chance that they were able to do so with a single dose of LSD. So obviously, this is a meta-analysis. There's intrinsic bias, publication bias, all sorts of other bias. But that said, as an addiction psychiatrist myself, I'm always intrigued when I see numbers like this to suggest that this could double the potential effect. Now, currently, LSD is not really heavily explored. One of the reasons that I think it's 9 to 12 hours is a long time. And so it's very labor intensive to study these compounds. And 9 to 12 hours would be challenging. So it's not really looked at very much for substance use disorders. The current pipeline for LSD use currently is MindMed has a compound called MM120, which uses a low-dose LSD that's being studied for anxiety use disorders right now. But comparatively, compared to other compounds, LSD, I would say, is not the one that is favored right now. Okay, next we'll talk about psilocybin, which is sort of the star of the show. So what is psilocybin? So structurally, psilocybin is 4-phosphoryloxy-NN-dimethyltryptamine. It's a substituted indole alkylamine. It's derived from the genus Psilocybe, which is a mushroom that's found all over the world. And these mushrooms, cubensis mushrooms, are pictured here. They're small, round, brown with some bluish tone, and they generally have anywhere from about 0.5% to 2% of psilocybin in dried mushroom. And so that translates when we think about administering psilocybin in terms of dosing. So most of the studies give 25 milligrams of synthetic psilocybin, which if you look at the numbers, depending on the concentration of psilocybin in the species of mushrooms, that's about anywhere from 4 to 5 grams of whole dried mushrooms, just for those of you who might know or want to know the equivalence. Yeah, that's all I'll say on that. In terms of safety, there have been some case reports of some pharmacologic toxicity noted, one being in 2012, a recipient of a heart transplant ingested psilocybin and then had a cardiac arrest, and so that was published. And there's been a handful of other studies or case reports of folks who have medical comorbidities who have had some bad outcomes. And that's largely because of its central sympathomimetic activation and can lead to some tachycardia and increase in blood pressure. And so for folks who are brittle in that domain, I would avoid these compounds. In terms of the pharmacokinetics, psilocybin has a relatively quick onset of action, about an hour, and it peaks in about 2 hours and lasts about 6 hours. Its half-life in its oral form is anywhere from 2 to 3 hours, and it is excreted renally. Now here we return to the radar plot to look at the subjective effects. And if you recall, when we looked at the subjective effects of LSD, we saw sort of a greater shift in the audiovisual synesthesia and elementary imagery, whereas in psilocybin we see what they say is a spiritual experience, a blissful state, more insight, which I think is interesting to think about and to kind of correlate that to its binding affinity. And also what's interesting about this plot in particular is that they looked in this plot of differences between those who responded for depressive symptoms and those who did not. And what you see here is those who responded had a more intense experience. And you've probably heard some discussion around the utility of the subjective experience. And there's increasing data to suggest that the subjective experience does seem to matter, and it does seem to correlate with outcomes, which is well demonstrated here. So for psilocybin, there's a handful of studies that have been completed for psilocybin for both tobacco use disorder and predominantly alcohol use disorder. And I'll just briefly go through those. In 2014, Matt Johnson, when he was over at Johns Hopkins, did a small pilot study of 15 smokers. These smokers smoked more than 10 cigarettes a day, and they all received CBT with 3 doses of psilocybin spread out over 15 weeks. And this was compared against a cohort of just CBT. And I'm sorry, I lied. They did not. This was an open label study. So they just, everyone got the CBT, and then they checked the urine codeine level, which was sensitive for 6 days, to test whether or not they were smoking or not. And what you see is on the first graph, the little laser's not really working. Oh, there it is. There you go. So cigarettes per day, time point at intake, they were smoking. Then they received psilocybin, and these are the numbers that were smoking at 10 weeks. These are the numbers that were smoking at 6 months, at 12 months, and at 30 months. So granted, very small sample, but again, having worked with a lot of smokers, if I had a panel of 10 patients and at 10 weeks only 2 of them were smoking, I would feel like an amazing doc. So when I read this years ago, I was really struck, and this paper is sort of the paper that gave me that initial intrigue of wanting to explore this more. This study went on, Matt Johnson got a large federal grant and is now completing a multi-site trial to explore psychedelic-assisted psychotherapy for tobacco use disorder, and we are all anxiously awaiting those results. Now moving on to alcohol use disorder, one of the first studies was done in 2015 by Michael Bogenschultz over at NYU, and this was an open label study where they took 10 alcoholics and they administered 2 doses of psilocybin separated by 4 weeks, and everyone got 12 weeks of motivational enhancement therapy. Their primary outcome was the percentage of heavy drinking days. And what you see here, so they came in drinking a lot. They enrolled in the study. You see the precipitous drop-off, which is very common in substance use trials. Then they received their first psilocybin dose. You see an ongoing drop. And then there was a statistical separation longitudinally up to 36 weeks thereafter in terms of reduction in drinking. And so it was this study that led to his team in 2022 publishing a larger trial where they took 95 adults with AUD, and this was a 2-site study at NYU and New Mexico. This was double-blind and randomized, whereas everyone received 12 weeks of manualized therapy with the 2 doses of psilocybin at week 4 and 8. And this was compared against a placebo condition where they administered diphenhydramine. And the primary outcomes were the percentage of heavy drinking days and mean drinks per day and abstinence. And here, what you see, similarly, people came in drinking a lot, enrolled in trial, stopped drinking as much. Then they took psilocybin, and those who received psilocybin in the blue significantly dropped off, whereas the diphenhydramine in brown remained ongoing. And you see the separation remained up until about 29 weeks after, which again, I think is quite impressive. Now, limitations of this study, obviously, blinding, which is true of all of these studies, is very challenging. Most people can predict the conditions they're in. So is there bias? Yes. Do I care? Not particularly as a clinician, right? If these things motivate my patients to remain abstinent or drink less, then I will take it happily. So there have been 2 additional studies looking at psilocybin for alcohol use disorder. And these 2 are interesting. A group out of France recently published a study where they looked at 30 adults in an inpatient unit who had both depression and alcohol use disorder. And they randomized them at a 2-to-1 distribution, whereas the active group received 25 milligrams of oral psilocybin twice, 3 weeks apart. And the randomized to control condition received treatment as usual. Now, in this case, treatment as usual was inpatient care. And remember, this is in Europe, so they actually have like inpatient services and care for people in a longer term way. And so the comparator, in the comparator condition, they did receive 1 milligram of psilocybin. And here, the primary outcome, this was a feasibility study, so really they were looking at how many people actually went through the protocol, and then their secondary outcomes were looking at things like abstinence rates and changes in drinking patterns. And what they found is that many people finished the protocol. Those who received the psilocybin, 95% completed it, so that was a success. In terms of abstinence rates, 55%, or 11 of the 20 who received the psilocybin, remained abstinent at 4 weeks, whereas only one person, or 11%, was abstinent at 4 weeks in that condition. But I think what's more interesting is that the craving frequency was statistically significant for the psilocybin condition, and people responded from a depression standpoint pretty robustly, which is interesting. What's also interesting is because this was done inpatient, they were allowed or able to work with folks who were on other medications, which is something that we struggle with here in a lot of our studies, where we take people off their SSRIs, off their mood stabilizers, which is very challenging, as you can imagine. But because this was inpatient, they were allowed to continue their meds and take psilocybin on top of them, which is somewhat rare. And there's somewhat of a cultural, myth or around sort of the risk of SSRIs with psychedelics. And what you see here is the folks who were on some sort of antidepressant, it essentially blunts the response. It doesn't seem to change it very much. So in the orange, you see the folks describing their experience on SSRIs, and in the yellow, those without. And you can see pretty clearly that it just seems to reduce the intensity of the experience, which I think was well demonstrated here, and may suggest that moving forward, it could be safe for us to use psilocybin with SSRIs at some point. We're not there yet, but it's an interesting thought. There was another really interesting study out of Switzerland that was just published, and they took 37 adults with alcohol use disorder and depression, and what they took the alcohol use disorder and they took all comers. So they didn't exclude folks who had other comorbidities like depression, anxiety, panic disorder, ADHD. And they stratified folks to receive either a single dose of psilocybin at 25 milligrams, combined with sort of a brief psychotherapy course of about 5 sessions. And they matched that with a placebo with the same psychotherapy conditions. And here the primary endpoint was the duration of abstinence and the mean alcohol use at 4 weeks and 6 months. And what you can see here is it didn't pan out. For these folks, there was no difference at 4 weeks or 6 months around the alcohol use. But what was noted, which I think is particularly interesting, is cravings. And what you see here is, this is the separation of drinking pattern over time. And you see, a separation here until about 12 days, which roughly corresponds to what we think of as the period by which psilocybin has sort of long-term neuroplastic effects. And it seems to suggest that perhaps there's some sort of anti-craving component in psilocybin. Yeah, I think that's an interesting finding that certainly warrants further exploration. So then, of course, shameless promotion on our work in our lab. So we have a study going on called the SILO study right now, where we're looking at the use of psilocybin with brief psychotherapy for veterans and first responders with both PTSD and alcohol use disorder. This study really emerged because I was interested in looking at data that better reflected the patients that I was seeing, which were higher risk folks. And the folks that have always scared me the most in my work have been folks with both PTSD and alcohol use disorder. And so we were able to convince the state to give us some funding to do this. We are currently enrolling right now. If any of you all have any patients who fit this domain, please send them our way. It's a randomized trial, 1-to-1 allocation with placebo, but then we have an open label enrollment, so everyone will receive psilocybin at some point. And our primary outcome is really, this is a safety study. We're looking at adverse events and suicidality and those sorts of things. And then our secondary interest is really in changes in PTSD symptoms via the CAPS-5 and changes in alcohol-related behavior via the timeline follow back. So we'll be enrolling until we hit our numbers of 40. I think we just enrolled our 4th or 5th participant right now. So that's that. We will see. Okay, I think we're doing well on time. I want to talk a little bit about ketamine just because there's a lot of interest in ketamine. It sort of straddles the legal and excitement around psychedelics. There's increasing number of weird clinics out there that are doing weird stuff, and I have all sorts of patients coming to me, especially post-COVID, who are receiving, troches and weird dosing. And so anyway, I thought I'd talk a little bit about ketamine because I'm certainly seeing clinically, I'm seeing it a lot more being used in psychiatry, and it's a unique compound. So structurally, it's 2,2-chlorophenyl 2-methyl-aminocyclohexanone. It's a phencyclidine derivative, first synthesized in 1962 to create a less hallucinogenic compound from PCP for anesthesia. It's, in terms of its brand and class, it's a Schedule III anesthetic. It's termed a dissociative anesthetic. It's currently branded as Ketalar, which is the racemic mixture, and Spravato, which is the S enantiomer of ketamine, and that's been, as you all probably know, FDA approved for depression. In terms of its dose, the sort of sub-anesthetic dose that's used for depression is about 0.2 milligrams per kilogram to 1 milligram per kilogram. And it has relatively low bioavailability. And so orally, for kind of psychedelic purposes, people generally take like 300 to 400 milligrams orally. In terms of its kinetics, it has a very rapid onset and peak. The duration is really variable based on route of administration. It has a pretty high bioavailability. Intramuscularly, orally, only about 20%. And like I said, a short half-life. Its mechanism is complicated. It has a lot of different effects. It's, I would say, a somewhat dirty drug. We don't fully understand all of its effects, but we do know that it seems to have varying effects on NMDA receptors, and then that leads to downstream effects in neuroplastic changes. So when we apply this to substance use, there was a handful of studies where ketamine has been used with psychotherapy to treat opiate use disorder. So Krupinski and colleagues in 2002 conducted a randomized crossover design of 70 adults with opiate use disorder, and they divided them into a low dose and a high dose group. And they all received 10 hours of existential psychotherapy before and then 5 hours after. And the primary outcome was opiate use confirmed by urine toxicology for 24 months. And what you see is that the high-dose ketamine is the dark one. So everyone came in, they had already been detoxed. So they came in abstinent. And then over time, each month went by, you see a separation between high dose and low dose that remains significant for most of that 24-month follow-up, suggesting that the higher dose experience seems to have a greater clinical impact. Now, this study was then followed up on, whereas not only did, so they just had asked the question, high versus low dose. Well, what about the number of doses? So in this study, Krupinski looked at 59 adults with opiate use disorder, and they divided them into 2 arms. One received 3 doses of ketamine plus manualized therapy, and one received a single dose. And again, what you can see here in this Kaplan-Meier curve is a separation by single versus multiple doses. It's not well illustrated by this graph, but essentially the take-home point is that it seemed as though more doses had a greater impact on abstinence over time. Now, moving on to alcohol use disorder, I think there's more interest in ketamine for alcohol use disorder given the pharmacology. We know that ketamine has some interaction with NMDA and GABA, and there's been some studies to show that when you use ketamine for things like alcohol withdrawal, it reduces the benzodiazepine need. This study was done back in 2020 by Dakwar out of Yale, and they looked at, this was a pilot study where they took 40 adults with AUD, and they stratified them to receive either IV ketamine, a single time, with manualized motivational enhancement therapy over 5 weeks, and they compared this to a group who received midazolam as their active control plus manualized therapy. And the primary outcome was abstinence rate and proportion of heavy drinking days. And this was a pilot study, very small, but what you see in the orange is that it does separate out. And the theory is that it's likely that you'd see a greater separation between the two had they chose a different comparator. Using a benzo in an alcohol use study seems like a poor choice if you're trying to assess the effect of another treatment. But it does seem to suggest that there was a separation, and they calculated and published that the number needed to treat was 4 in terms of reduced heavy drinking. But obviously a lot more work needs to be done on that. So this study by Grabsky and colleagues, I love this study. This is one of my faves. This is a phase 2 double-blind study that looked at relapse prevention for alcohol use disorder. And so here they took 96 adults who had severe AUD and who had recently been detoxified, and they stratified them into 4 conditions. So the first condition was ketamine plus psychotherapy. The second condition was ketamine plus psychoeducation, which they're sort of using psychoeducation as the placebo condition for therapy. And you ask, well, what's the difference? Well, the difference is in psychotherapy, it's bidirectional, right? It's like a relational, it's interactive, whereas psychoeducation is more single direction. Me as the provider, I'm telling you what you have and what's going on, right? So that was used as sort of the placebo condition for the therapy. Then the third group was placebo, ketamine, plus psychotherapy, and the fourth group was placebo for ketamine and psychoeducation, so sort of placebo. And you see this beautiful separation between the 4 conditions, whereas they wasn't powered to see separation in all 4 groups, but the ketamine plus psychotherapy clearly separated from placebo plus placebo, which suggests that the active ingredient here is more than just the pharmacology. It's probably the psychotherapy as well, which seems obvious for anyone who works in mental health, but I thought they did a nice job in trying to illustrate this. And I've talked to this team, and they had a lot to say about it. But the hope is that they'll replicate it with a larger sample and see if we can better stratify those groups. Okay, so we've covered 3 different compounds, and how is this happening? Why would someone be interested in the use of psychedelics for substance use disorder? So there's a lot of different mechanisms, all of which are very hand-wavy at this point. We don't really know how they work. But one lab out of Berkeley, Dolan's lab, is doing some really interesting work that, to me, makes sense. So here you see an animal model where they used social preference score in animals over time at different ages. And so what you see here is younger animals learn, you can think of the social preference score as sort of a proxy for learning, right? So younger animals, they learn faster than older animals. That tracks, right? This is why kids are in school and learn music and instruments, and I'm like super slow and it takes a long time to get things done, right? Their brains are sort of in this sort of plastic period. And then they gave those same animals, the older animals, MDMA, and suddenly their ability to learn seemed to exceed the younger animals. So it seemed to suggest that perhaps MDMA, anyway, is opening up this sort of neuroplastic period where there is an enhanced degree of learning. And they went on to use this paradigm to look at the duration of this neuroplastic window by compound. And a lot of this tracks in what we're seeing clinically if you look at observational data. If you look at ketamine for depression, for example, most people will tell you, yeah, it made me feel good for a day or 2 or 3, and then the effects seem to quickly fade off. For psilocybin, same thing. People often say they feel good for about 2 weeks, and then things start to fade off. In the psilocybin for AUD study, the craving score seemed to change at about 12 days or 2 weeks. Similar for MDMA. For LSD, a little bit longer, more like 3 weeks. And then ibogaine, which we didn't talk about today, has a much longer period of about 4 weeks. But to me, this idea of neuroplasticity is sort of the unifying theory that helps me put all of the different potential mechanisms into a single bucket. Now, Bogenschultz did this really lovely paper years ago now that I really love. And basically what he posits is that there are specific elements of the drug, of the participant, and the setting. And those different elements lead to specific brain effects and specific psychological effects. Those things lead to persisting effects, which could include things like neuroplastic changes, which we just talked about, but also changes in mood or anxiety, and some changes in personality, changes in beliefs and values, which ultimately lead to this kind of final change mechanism, which is hypothesized to be one of reduced cravings, enhanced self-efficacy, and increased motivation. And then, and only then, do you get to reduce substance use. What I like about this graph, or this chart, is that it just highlights the number of variables that affect someone's use of a substance, right? It is a complicated interaction that is certainly not unidirectional, but I think this just highlights how many different ways in which psychedelics may play a role in some people's change in behavior. Okay, so safety. Yeah, so there is sort of, when folks come to you and say, hey, should I go take psilocybin to feel better? I'm sure many of you don't quite know how to respond to that. And so whenever people ask me this question, I sort of think about safety and psychedelics in sort of three different buckets. Those buckets include sort of pharmacologic safety. Is the drug itself toxic? Is the drug itself going to kill you? The second domain is sort of psychological safety. Do you have the personality structure, the flexibility, the ability to sit with the distress that psychedelics may induce in you? And the third one is around situation and situational safety. Are you doing them at a party in some random person's house? Are you doing them in a clinical trial? And I think for each of these three domains, there are different sort of risks and benefits. And so what I tell people is, say, use psilocybin as sort of the classic example, because I think that's where there's the most kind of cultural interest right now. So pharmacologically, is it safe? Yes, it's very safe. It has a really, really wide range of dose. It's not a very toxic compound. So pharmacologically, probably pretty safe. Psychologically, though, I think there is a growing concern that it seems like some folks really cannot tolerate the stress associated with one of these experiences. I sort of think about it like a cardiac stress test. If you don't have the resilience or the coping skills, the intensity of the psychedelic experience could become incredibly destabilizing. And I've certainly seen that in a number of folks. And so for psilocybin, the questions that I often ask are, do you have good support? Are you able to sit with distress? Do you have distress tolerance skills? Similarly, do you have any risk of a psychotic disorder? The interplay between psychosis and psychedelic use is complicated. It's not black and white. Most studies exclude folks who have any sort of risk of developing a psychotic disorder. And I've certainly seen people where temporarily they are fine, they take some sort of psychedelic, and then it seems to sort of unmask or amplify symptomatology of bipolar disorder or a thought disorder. That does occur, although exceedingly rare. But I think from a safety perspective, it's really important to sort of triage out and make sure that people don't have high risk for any sort of thought disorder. And then in terms of situation, my big concern is, especially right now, where there's this growing sort of anti-medicine, anti-science movement occurring, there are a lot of folks who I think are interested in psychedelics in large part because it's sort of anti-mainstream, anti-psychiatry, which, look, I get it. We all need to find our path that makes us feel good. I do worry, though, about there are a growing number of folks who, work in tech and then go do ayahuasca, and now they want to be a shaman and they want to stuff you full of ayahuasca. And that concerns me. They may have the best of intentions, but do they know anything about how to assess someone's safety for these things? Probably not. So much of my conversation with folks is around how to ensure that you're safe and that there aren't any bad outcomes. You're also taking a population who are often desperate for some sort of treatment, and so they're at high risk for exploitation. People with trauma, they're doing something illegal. So that is more of my concern, is that people make choices with their safety in mind. And that includes like retreats and those sorts of things. Okay, so, we're in this time right now where states are increasingly developing programs to allow access for psychedelics. And I think that's causing some confusion, whereas some folks feel like, okay, if I can go down to Oregon and go to a facilitation center and receive psilocybin, then it must be fine. And there's sort of this permissiveness that I think is increasing culturally around its use. But I do have concerns. I think it's a little odd that states would develop administration methods of a specific compound. I mean, imagine if there was a chemotherapy administration, if there was a program where you could get an experimental chemotherapy without any doctor's referral, purely on your own. It seems a little odd that we would sort of legislate access to these compounds. And yeah, it seems a little peculiar. And I think with cannabis, we've learned that some of these state legislated programs can lead to some unintended harms that we're seeing now, and that is certainly a concern of mine. Oregon passed legislation, Colorado has, New Mexico just did. There's about 20-something states where this is an ongoing debate. And it's a complicated debate, and I certainly don't have the answers. But when patients come to me and they ask about access, I often will point to them. This is from the phase 3 MDMA study where they were using MDMA for PTSD. And what this shows is in the red are the responders and remitters with MDMA, and the blue was the placebo condition, just the psychotherapy condition. And what's really amazing to me is in this trial, almost 30% of folks who were in the placebo condition lost the diagnosis of PTSD after this treatment. Independent, not even receiving MDMA, just having focused PTSD-specific psychotherapy. And some may say, oh, well, that's just placebo responders. Again, I would say almost 30% left this study without a PTSD diagnosis, which is pretty remarkable. I certainly don't see that in my clinical practice. And I think it highlights this complex interplay between the psychotherapy and the psychedelic. And I use this to illustrate to folks that, psychedelics by themselves are certainly not going to lead to you curing your alcohol use disorder or your depression. And we know that if you look at the naturalistic data. Tons of people have used psychedelics recreationally, still go on to develop problems. The difference seems to be this sort of container that it's administered in with some sort of psychotherapy. So to me, and this is just my personal opinion, psychedelics, their primary mechanism is that they are sort of an enhancer of motivation, but you need to target that motivation into something behavioral. And that can be said for depression treatment, anxiety treatment, OCD treatment, what have you. And so I just try to reassure patients who are sort of feeling desperate, like they need this treatment, it's their last hope, that there are still a lot of opportunities to improve their lives without necessarily engaging in this treatment right now, although they could, and that's their choice. But we certainly need to better understand the long-term effects, and there's many, many, many questions that we are yet to fully elucidate. So with that in mind, this is a great chart by a great group called Psychedelic Alpha, and they track all of the kind of biotech companies in this space. And what you see here in substance use disorders are in that corner triangle, my pointer's not working, is all of the different studies being done right now. I know it's small, but basically the outer ring are phase 2 studies, the middle ring is phase 1, and the target in the middle is approved. And in the outer ring right now, there are phase 2 studies going on for opiate use disorder using psilocybin out of University of Alabama. And there are studies looking at S-ketamine and ketamine for alcohol use disorder. And there's also a 5-MeO DMT study for alcohol use disorder as well that's currently underway. So there's certainly a lot of interest, and the pipeline is very active, and things are happening. So I suspect we will continue to see studies as we move forward. Alrighty, so just some resources for you all. These are resources that I point patients to go to who are interested in learning more. Zendo Project is a great organization. I do teach people and patients to go to clinicaltrials.gov if they want to pursue this and show them how to actually look for clinical trials. Of course, explaining to them that the likelihood of enrollment is very, very low, less than 1%, but gives them some behavioral activation opportunities. So I teach them to do that. Psychedelics in Recovery is a great group. They are a 12-step facilitation group that is psychedelically friendly. And so they sort of use 12-step with psychedelics, and people often find that helpful. Psychedelic.support is a great educational resource for providers and for patients. And then, of course, MAPS, Johns Hopkins, they have a lot of good research. And then there's some, the ASKP is a ketamine group that has some good data. And there's a great book, Handbook of Medical Hallucinogens, that is an awesome textbook that I often use with residents. And that is it. Questions? Yeah.
I'm curious when you, in
Oh.
all of the studies.
We've got a microphone.
Oh.
Thank you for all of this really helpful information. I'm curious from the studies, when a lot of them had administered a psychedelic and then saw, after that 2-week period or a 3-week period, symptoms return. If this were used, like if you were to just be, prescribing this to a patient, would the prescription then be every 3 weeks take this dose?
Yeah, that's a great question. And I think we don't have good data on the effects long-term of multiple administrations beyond 6 months. So there is a lot of work that needs to be done to understand the long-term effects. The way I suspect it'll look pragmatically is it'll sort of look like Spravato did a couple of months ago when the indication was in conjunction with an SSRI. It'll be sort of an adjunct treatment is what I suspect. But to your point, the dosing regimen, there's still a lot of work that needs to be done to really show what's the ideal route. And I think also there's an interesting opportunity to look at things like the dosing paradigm, like micro versus macro dosing. And in the substance use world, I think that there'll be some interesting studies coming down the pike around the use of targeting, say, microdosing for relapse prevention. So that could be a sort of standalone treatment. But that's a great question and to be determined.
I'll go next. Thanks, Nathan. I found those radar plots fascinating,
Yeah.
and we probably don't know the answer, but I'm wondering what your thoughts are on the role of anxiety. I noticed that the non-responders had more anxiety than the responders, and if that could be an effect. But also the ones taking SSRIs. The SSRIs seem to reduce the synesthesic effects, but not the, was it oceanic connectedness or something, a cool name like that.
Yeah.
But I'm just wondering if there is an effect on treatment outcomes based on the experiential effects.
That's a great question, Robin. I think, so Robin Carhart Harris did a study where they administered psilocybin with escitalopram and actually showed that in that study, folks that took escitalopram and psilocybin had less anxiety associated with the dosing session, and which was interesting. There's an additional study that showed the inverse, that co-administration seemed to increase people's anxiety. So it's really hard to tease that out at this point. It's also hard to tell, like, when you're doing these studies, what is an adverse event? Like, anxiety might be part of the therapeutic process of sitting with the exposure of your PTSD, right? It's going to make you feel anxious by definition. Is that an adverse event relative to the compound, or is that relative to the therapy and part of the process? And that's something that the research has still not really done a great job at differentiating. Yeah, that's kind of a roundabout answer to your question, but that's what I got.
I'm wondering what specific data there is for OCD and psychedelics.
Great
the
question.
reason I'm asking is I'm finding some people going directly to ketamine
Yeah.
as if it's the first line treatment.
Yeah. So in preparation for this talk, thinking that there would probably be a question about OCD. Yeah, so OCD does seem, so there's a handful of pilot studies that have showed good effect for psilocybin for OCD symptomatology. It remains to be seen. I mean, I don't know what your all experience has been. You probably all have a lot more experience than I do with OCD. I find that our diagnostic specificity is so poor with OCD that and if you look at the studies, it's really hard to tease out the confidence of their diagnoses to really know. But the short answer to your question is, of the psychedelics being used, I would say that psilocybin seems to have the most promise for OCD in the short term. Now, these are all been studies in adults, not in children. And for ketamine, I am not aware of any data to suggest that ketamine, maybe some case series, but I don't think there's been actually any studies to date of ketamine for OCD. It also brings up this interesting question for all of these indications. I wonder about this for our trial, for our PTSD and AUD trial. Like, if we're administering psilocybin, to what extent is the effect from treating the depression, which is part of the constellation of PTSD, versus the PTSD symptoms themselves? And I feel like this is an ongoing question that we're still trying to tease out, and I think that applies to OCD. Are you treating the anxiety associated with the OCD? Maybe. But yeah, there's still a lot we need to explore in that.
Thank you so much. And I had a question about the patients who had the overdose and went to the hospital. To what extent is there overlap of the syndrome and overdose with serotonin syndrome? And is there a thought that these agents may potentiate serotonin syndrome when someone has an overdose with SSRIs?
Yeah, that's a great question. So yes, serotonin syndrome is often a concern kind of culturally or among ED providers. The reality is it really depends on the compound. For LSD and psilocybin, while they are serotonergic, the likelihood of inducing a serotonin syndrome is exceptionally rare, exceptionally rare. Because these are not, they are serotonergically acting, but they're not like reuptake inhibitors. They're not increasing the extracellular serotonin amount. And so it's very, very rare that they could lead to a serotonin syndrome. What's more likely is that you could receive, or you could develop a serotonin syndrome with something like MDMA, which has a lot of SERT activity, or even ibogaine, which has some SERT activity. That is a possibility. But in terms of serotonin syndrome, the way that we traditionally think about it, it's actually very, very rare from the for a classic psychedelic like LSD, psilocybin, DMT, to induce a serotonin syndrome.
Hi, my question has to do with the lost opportunity of maybe some research that could be done after people happen to have the psychedelic experience but aren't in a trial.
Mm-hmm.
I've been, we see families and kids here. I've been contacted at least 4 times by people that do this thing where they get with their bro friends, jump on airplanes, go to Colorado, go to California. Mm-hmm. They're activated in some of their issues around alcohol, depression, anxiety. They know me from 10 years ago, 15 years ago, so I called, so I do some work with them, and there's so much integration work that can be done after the experience to really good outcome, but it's lost data if somebody doesn't do a retrospective kind of analysis about that, because they're not in clinical trials. Yeah.
So you bring up a great point, which is because of the complexity of conducting these trials, both the complexity from a cost perspective, I mean, they're exceedingly expensive, and just logistically, working with a Schedule I compound is a pain in the butt. I do think that we need more sort of pharmacovigilance studies and better use of observational and naturalistic data. So our lab have sort of leaned into that. We work with a number of retreats and look at naturalistic use and then follow them longitudinally to sort of see real world outcomes. And I agree, I think that it is a real missed opportunity, both from a data perspective, but also from a therapeutic perspective. I have a clinic over at the U called the Psychedelic Education and Harm Reduction Clinic, where I take consults for folks who are interested in psychedelics, either because they've done psychedelics and have some harm, or they're interested in pursuing psychedelics for therapeutic purposes. And so I do some of the preparatory work and integration work thereafter and try to help steer them in a direction where they won't induce more harm. And it's certainly been interesting to see how many folks are more than willing to fly down to, South America to do ayahuasca, but very reluctant to talk about it with a therapist, which I always find very interesting. So yes, I agree. If you know of any funding to help us continue to collect naturalistic and observational data, give me a call.
So just things are spinning in my head, and I told you that before you started today about all of this. And, so just a couple of broad observations, and then I have a more or less specific question for you. One, I'm terribly concerned about ketamine farms, and so there was this crazy person at ACAP last year who was talking about giving kids hundreds of doses. Yeah, exactly. Your head spins around all that. And she was dressed with hippie clothes, and she was from Berkeley, and you know what about that personally. And so there's that. And then just by other way of personal disclosure, I'm not big into epiphanies. It just hasn't happened for me yet, and it's getting late. And so that said, it does sound like this is, at least on some level, tantamount to an epiphany or something. And you talk about neuroplasticity, and you were saying this hasn't been done with kids. I mean, arguably, if there really were something to a neuroplastic construct, a kid would be more sensitive to changes that might happen. So all that to say, I mean, it sounds like you sort of believe this on some level. I'm not quite sure how deeply you actually hold it in your heart, but do you think that there is some suggestion of actually some neuroplastic event that happens, or could happen, or could facilitate something else happening in terms like, and essentially is, what the hell is this?
Yeah, great question, great question. How do I answer that? Yeah, I mean, I think, look, from a sort of psychological perspective, I think that for a lot of folks, an experience like this is an opportunity for them to sort of step out and mentalize their own life from a different angle, like, sort of using jargon. But I think there is something to be said about, particularly for folks who struggle with addiction long term, they get this narrative that sort of loops in their mind over and over and over, and they become increasingly identified with that narrative around who they are and their weaknesses and failures and so forth. I do think that where I have seen psychedelics be helpful for folks is it gives people the opportunity to challenge some of those assumptions in a very concrete way. And I have seen that catalyze behavior change in very helpful ways. To your question, is that a neuroplastic event versus a more experiential psychological event? I mean, yes and yes. I think they're probably bidirectional, right? We know that behavior also induces neuroplasticity. We know that neuroplasticity occurs in placebo responders. So neuroplasticity is not like a unique biological phenomena that only is one direction, right? So I think there's a lot of things happening, and I think it's somewhat reflective of the complexity that we're dealing with when you're dealing with human behavior. Like, looking at addiction, like we can't even, if I were to ask each of you what addiction is, I'd get 50 different answers, right? Like we don't even necessarily agree culturally on what it is to be a user of a substance in a problematic way. So to your question, I think it's complicated. I think we don't know. I also share your concern about ketamine. I think I have seen more ketamine use disorder patients since COVID. That's very concerning. And I think it's ironic that ketamine, which is legal, has the highest abuse potential and has the most, sort of rewarding properties. But, that's we all know that public policy, particularly on public health, does not correlate with rational science. So it's sort of congruent with where we are, unfortunately. That doesn't really answer your question, but does that sort of scratch the itch?
I just wanted you to talk about it.
That's fair.
I knew there wasn't an answer. I wanted to hear your musings about it.
Well, there you go. I'm mused.
More of a compliment, but would love to hear you expand on it a little bit. I just found very helpful the slide you have about the 3 buckets of ways that you talk about safety of a substance. And working with adolescents who experiment with a lot of this crap, it's really helpful to think about the toxicity of the drug as separate from the psychological experience and separate from the setting, and how all 3 of those can interact. And I'm going to use that, so thank you.
Yeah,
I assume this applies, my inference is that this applies to more than just these psychedelics. Yeah. And just curious if you have kind of language that you use to share this with patients, especially maybe more adolescent-friendly language that you could expand on?
Yeah. I think I will say this. Probably the wrong audience to say this, but like kids and adolescents scare me. Having 4 of them myself, they terrify me. And clinically, I find myself often challenged with how to navigate some of those complex conversations. But I think the approach that I have always taken with patients of any age, I hope, is sort of that of harm reduction, which is, people are going to experiment. That's somewhat natural. We know that. And the best thing that we can do as providers is give people the information and try to encourage them to make safe choices. I think, for adolescents or even like younger folks, I kind of consider like up to mid-20s to be adolescent, but I sort of think about just situational safety is really the big concern. Sexual exploitation, molestation, all the weird stuff that can happen. So I sort of lean into that, and I know that's probably like scare tacticy and probably not what I'm supposed to be doing, but I feel like I have a duty to be honest of like, look, I see this, I see bad outcomes. And if you're gonna experiment, don't experiment like at your friend's older brother's party on a Friday night where you don't know anyone. Like, that's not the space to do this. And try to lean into the idea that, you only will get what you want from this if you put in the thought and work to sort of set yourself up for success. That's sort of the language that I use. I don't know how it lands, but yeah.
Hi, my name's Ash. I'm over here. Hi. I'm a case manager on the PBMU, and a little setup for this question. I'm also an enrolled tribal member to a tribe in the Caribbean, Hiiaqua, identified member of like Biwa-Isa, which in English is like Two-Spirit. And then in like the mid-2010s is when these studies started really coming out. So I was in like 4th, 5th grade, toggling back and forth between like a behavioral neuroscience degree, going into like kind of tribal community spaces, working in adult psychotic spaces, so seeing like the, too far kind of a thing. In particular, I'm interested about the study that delineates into those 4 categories with ketamine of like psychoeducation, psychotherapy. And I wonder if there's also a place for, I think going to the very beginning of this presentation of the delineation between the medicalization of these and the psychospiritual, I have this growing skepticism that keeping those delineated long term will lead us to the most fruitful outcomes for what these can do for like our society. So do you see there being a like 3rd testing category that's not just psychoeducation, psychotherapy, but also shamanistic integration / what kind of modalities are being used in the psychotherapy that might be actually mimicking that?
It's a great question. We recently did a qualitative study of members of ayahuasca churches. Now, obviously, it's slightly different, but the way that I sort of conceptualize the sort of psychospiritual use for folks is, it provides a container, and if the language is congruent for you and the language makes sense, for many people that's a really comforting space, and it provides them sort of structure, both acutely while they're under the influence, but also sort of from an integration perspective, and they can sort of use the stories and the narratives and the metaphors of whatever cultural construct they're experiencing that in, and I think that's great, and I think that certainly has merit and value. I also think there's a lot of folks who that language doesn't resonate with, and how do we create different spaces for folks to use these compounds therapeutically in a safe and thoughtful way? And I certainly don't have the answer. That's a very huge question. And then I think just more practically, I do think that certain compounds lend themselves to, say, group administration versus like a solo administration. For example, like ayahuasca, I think there's something permissive about being in a room with a bunch of people getting weird, whereas if you hear other people getting weird, it kind of gives you permission to get weird, and there is this sort of contagion effect where you can lean into the discomfort more in the safety of a group where there's like clear boundaries and rules. And so yeah, I think there's a lot of interesting stuff there and a lot of interesting opportunities. And I think especially as we see these compounds getting commercialized, I expect there's going to be another wave of research that look at different modalities to put on top of them, whether that be group models or whether that be, retreat models or, but there's a lot there that we still need to explore.